Evening, sir.
Yeah, good evening. Chalo, we can start. Huh?
Yes,
Yeah.
sir. Yes, sir. Just give
So,
me 1 minute.
good evening, all the aspirants present here. Today's topic is status epilepticus, and the speaker that we have here is Dr. MONALISHA Mishra. She is a senior consultant in critical care at Apollo Multispeciality Hospital, Kolkata. Here we have the moderator, Dr. BANAMBER, who is HOD of Critical Care Medicine at Some Ultimate Medicine, Bhubaneswar. We also have the moderator here, Dr. Kishore JHUNJHUNWALA. He is a director in critical care medicine at Jayaprabha Medanta Super Speciality Hospital, Patna. He'll be joining us soon. And the organizers we have here is Dr. Akhilesh Tandekar, Dr. Gunadhar Padi, and Dr. Asif Iqbal.
So we'll start with today's topic is status epilepticus. It's very important topic for everybody who works in ER, works in critical care. So let's define what is status epilepticus. So Sana, just one clarification. You asked everybody to mute their mic, but they can answer no, like if they want, if I
Yes,
ask some questions.
they
Yeah.
can answer.
Yeah, okay, great. So basically, any episode of seizure that is lasting for 30 minutes or 30 minutes of recurrent seizures without return to the baseline neurological status between the events is actually status epilepticus. But now, actually, it has been replaced by an operational definition. And what does that say? That in which you have 5-minute duration of continuous seizure or 2 or more seizures in which there is incomplete recovery. So this is the current operational definition of status epilepticus. So this is the International Anti-Epileptic Society definition in 2015. The condition resulting from the failure of mechanism that is responsible for seizure termination or from the initiation of mechanism which causes abnormally prolonged seizures after the time point T1. And status epilepticus can result in long-term consequences after the time point T2. So based this time is actually defined depending on the type of seizures, the tonic-clonic status epilepticus, the focal status epilepticus with impaired consciousness, and there is absence status epilepticus. So these are the 3 types of status epilepticus. This thing had come in Neurology India 2017. So these are the forms of status epilepticus as we already discussed. So generalized is there and then focal is there. Generalized can be primary or secondary focal onset. Myoclonic, which can be tonic or clonic or atonic. And then there is focal, which is motor focal status epilepticus. And then there is non-convulsive. So when it's non-convulsive, it's typical classic absent non-convulsive status epilepticus and other primary generalized non-convulsive status epilepticus and typical absent non-convulsive status epilepticus. So these are the various types. Now, what is refractory status epilepticus? So anybody wants to unmute and say what is refractory status?
It's high status that does not respond to either benzodiazepine or the first line therapies.
Okay. So basically the one which is very good. So this is the one which doesn't respond to the standard treatment regimen. That is adequate doses of initial benzodiazepine followed by a second acceptable anti-epileptic drug. And just to put things in perspective, 40% of status epilepticus can actually turn to be refractory. And it is more common in causes like encephalitis, non-structural causes of hypoxemic ischemic encephalopathy, and sometimes because of delayed diagnosis or delayed treatment also, there is an increased risk of going into refractory status epilepticus. Super refractory status epilepticus is a term like that. Anybody wants to tell what is super refractory status epilepticus?
Super refractory is if the patient continues to have seizures despite general anesthesia And I think that you can literally potentially pick it up only on EEG.
So that continues for more than 24 hours, or what you said, more than even after the use of anesthetic therapy. So very good. You were partially, you gave the answer, but also if any refractory seizures which is continuing for more than 24 hours, it becomes super refractory. It also includes the cases when you start weaning the anti-epileptics and again the patient starts having seizures, that is also super refractory. And it goes without saying that if somebody is having super refractory status epilepticus, it is associated with high morbidity and mortality. So we are clear with the definitions of status epilepticus, refractory status epilepticus, and super refractory status epilepticus. Now, new onset refractory status epilepticus. It's basically a rare thing. It occurs in patients who have no cause, who were otherwise absolutely healthy. And most common cause, it's very important for if anybody asks like an MCQ, the most common cause is autoimmune encephalitis. Unidentified viral infections leading to autoimmune encephalitis could also cause new onset refractory status epilepticus. So it's actually, we saw a few cases of herpes simplex encephalitis leading to new onset refractory status epilepticus. We have presented a few cases like that also. It's a clinical presentation, not a specific diagnosis. In a patient without active epilepsy or pre-existing relevant neurological disorder, with new onset refractory status epilepticus without a clear acute or active structural cause, toxic cause, or metabolic cause. So this is how we define new onset refractory status epilepticus. Similarly, we have something called febrile infection related. So there might be an overlap. It's a subcategory of new onset cyst refractory status epilepticus. That any febrile infection, or the febrile infection could be viral encephalitis also, starting between 2 weeks and 24 hours prior to the onset of refractory status epilepticus, with or without fever that is there at the onset of status epilepticus. That is called as febrile infection-related epilepsy syndrome. Now, common etiologies of status epilepticus, convulsive, non-convulsive, both. So we have traumatic brain injury. We have various types of stroke. It can be ischemic stroke. It can be hemorrhagic stroke. It can be SAH. We have hypoxic ischemic damage, anoxic brain injury. We have various medications like antibiotics, like third generations, fourth generation cephalosporins. We have sorry. So we have cephalosporins, penicillin, imipenem, all of these antibiotics. Anything else which is missing from the list you guys want to add in the antibiotics list? So cephalosporins, you have ceftrazidime, cefepime. Then, of course, there is lithium. Lithium can induce toxicity. Withdrawal of certain drugs can also precipitate seizures, like benzodiazepines. And of course, there are infectious causes. So these are the various common etiologies that are associated with non-convulsive status epilepticus. Now we'll come to management. So it is an emergency. We have to treat it immediately in critical care setting. The mortality rate is around 20%. And pharmacological intervention, whatever you want to do, you have to do it as early as possible because it's more effective then. So what is the aim? Aim is to terminate the current episode of status epilepticus. The aim is to prevent recurrence, to manage the cause for which this happened, and to manage the complications associated with it, right? So initial management in the ED. So for every emergency, we all know that we have to do A, B, C, D, E. But here you have extra one A, B, C, D, E, F, G. What does G stand for here? Anybody?
Can
What
I
is
guess
A, B?
glycemic control, I'm assuming?
Glucose. Yes, very good. glucose. So glucose has to be checked in a patient who is coming to your ED with seizures. So call for help is the first step, because you can't do this alone. You will definitely require a lot of help. So call for nursing help, call for your whoever is available, call for your doctors, junior doctors, senior doctor, whoever is available. A, B, C, D, E, F, G, don't forget the capillary glucose. Airway has to be protected. So for that, either the patient has to be in lateral decubitus position or head up position to prevent aspiration. Attempt IV access, obviously, because you have to send bloods. So you have to send blood to see VBG, glucose, electrolytes, tox screen, and lorazepam has to be given. So how much lorazepam we give initially? We give 4 mg. And we repeat it after 4 minutes. If no response after the first benzodiazepine, we think of starting the second anti-epileptic. So prepare to intubate via RSI, because there might be a chance that you might require intubation. What is RSI?
Rapid sequence intubation.
Yes, rapid sequence induction. So consider immediate life threats that require immediate management. For instance, like hypoxia, hypertension, whatever was the cause that you need to treat. Metabolic causes that needs to be addressed. For instance, hypoglycemia needs to be addressed. Hyponatremia, you need to give 3% saline. Toxicological findings. So can you name a few toxins which can actually cause seizures? Anything, like any broad poisoning, any poisons which can cause seizures you have seen in your clinical practice sometime? Any interesting case?
Tricyclic antidepressants.
Tricyclic antidepressants definitely can cause seizures, and sometimes the acid you have to give bicarbonate for that. Yes.
Aminophylline.
Sorry. Yeah, aminophylline can cause seizures. Very good. Yeah. What else?
Amphetamines.
Valproate.
Yeah. Well,
Sodium
antihistamines
valproate.
can cause
Flumazenil
seizures.
in patient in chronic benzodiazepine. Flumazenil.
Yes. Yes. Okay, good. Yeah. Flumazenil can sometimes precipitate seizures as well. And if it's eclampsia due to pregnancy, what is the drug of choice?
Magnesium.
Magnesium sulfate. What is that
MG.
regimen called? MgSO4 regimen for treatment of seizures?
Richard and
4
Zospir.
grams.
Yeah,
That's
Richard.
followed by 1 gram per hour.
Correct. Correct. So this is what you have to remember, because these are the immediate things you have to simultaneously take care of while taking care of the patient who is having status epilepticus. That's why you need hands. So EEG has to be done as soon as possible after the diagnosis, optimally within 1 hour. During treatment, EEG should be reviewed immediately and then periodically until the status epilepticus has been controlled or a best separation has been recorded. Until the seizure is controlled for 24 hours, you have to do a continuous EEG monitoring. So after the first dose of benzodiazepine and one anti-seizure medication, we have to make sure that we have an IV access or IO access. If it is not secured, then you have to give probably IM midazolam or intranasal midazolam or rectal diazepam, and give first dose of anti-seizure medication as soon as you establish IV access. But if you have given the first dose of benzodiazepine and you have secured the IV access, then you can straight away move to the first dose of anti-seizure medication. So after this also, if the seizures are continuing, you have to give the second dose of benzodiazepine. And despite of that, if the seizures are continuing for 10 to 15 minutes, then you have to call a neurologist and obtain a portable EEG. After that, 15 to 20 minutes, if you're not able to control seizures, then if possible, prepare the patient to be transferred to ICU. And actually, 15 to 20, you have to consider rapid sequencing and use vasopressors. You will need vasopressor support. Okay. So till what did you hear? Did you hear about the seizures continuing beyond 30 minutes? And after that, we have to do rapid sequence induction, start mechanical ventilation, begin continuous EEG monitoring, start continuous infusion with midazolam or propofol or phenobarbital to control seizures, and use NORAD, vasopressin, whatever is necessary, because all these medications will cause low blood pressure. So this slide is very clear. We'll move to the next one. So this was a recent trial which was done in 2019, where these three anti-epileptics were tested, Levipril, fosphenytoin, and valproate. And these were the doses of these three anti-epileptics that were tested. And it was found that there was no significant difference in the rate of seizure cessation in among all the three. So all the three were the same. So between phenytoin and fosphenytoin, though basically the time to seizure cessation is comparable, but theoretically we prefer phenytoin. And there are a lot of reasons for that. One is that it is a water-soluble compound, so there is faster rate of infusion. You can give it quickly. Second thing is doesn't precipitate in IV solutions. Third thing is that like phenytoin causes cardiac arrhythmias and hypotension. This thing causes fewer cardiovascular side effects. Other thing is that tissue side effects like purple glove syndrome, extravasation and all is also less with phenytoin, fosphenytoin compared to phenytoin. But because fosphenytoin is slightly costlier, that is why we still continue to use phenytoin in some places. But avoid both these agents where if the patient was already on these agents and had status epilepticus, because probably they're not working. That is why even if the patient was appropriately dosed and you are having seizures. Sana, you please let me know any issue with the internet or anything happening. Else I'll continue teaching. And also, if there is any suspected toxicological cause of seizures, then then avoid these agents because these agents are again sodium channel blockers. So everything together will cause sodium channel blockage. So for instance, your TCAs, tricyclic antidepressants are also sodium channel blockers. Phenytoin is also sodium channel blockers. So in suspected cases of toxicology induced seizures, we have to avoid fosphenytoin. And also, if the patient was already on fosphenytoin and phenytoin, we should not give that again because probably they were not working. We have to use other anti-epileptics. Now, how about propofol as a second-line anti-epileptic in status epilepticus? So the recommended dose is 2 mg per kg. And it has also actually been shown in concept and eclipse trial that it is quite effective and it takes around 30 to 45 minutes until the seizure actually happens. Propofol, we all are very familiar with, isn't it? Many of us are anesthetists. We have used propofol throughout our life. So it's readily available. It is familiar. It can be given quickly. It has a rapid onset of action. And another very important point is that there is a safety of propofol in a suspected toxicological case also, where phenytoin and fosphenytoin might not be successful. So propofol is not a bad agent as a second line in anti-epileptic therapy. So what medications and the doses we'll discuss in brief. So lorazepam, as you all know, it is 0.1 mg per kg or IO, max up to 2 mg per minute. Alternatively, you can do as 4 mg of fixed dose, or you can give diazepam, or you can give clonazepam. If the IV or IO access is not established within 3 minutes, then you have to give midazolam IM, that is 10 mg, or buccal midazolam, that is again 10 mg, or intranasal spray of midazolam to each nostril, that is 10 mg, or rectal diazepam or intranasal diazepam. So these are the usual anti-epileptics that are available. So after this, you have the 3 drugs which we already discussed, which was also compared in the trials, Levipril, fosphenytoin, and valproate in the respective doses. Levipril dose is 60 mg per kg IV. Maximum you can give up to 4.5 grams over 5 to 15 minutes. Fosphenytoin, you can give 100 to 150 mg per minute. And valproate 40 mg per kg or maximum 3000 mg or 3 grams you can give at 10 mg per kg per minute. So these are the various anti-seizure medication doses you should know of. So for refractory status epilepticus, if the patient is continuing to seize after the first and second line treatment, you have to consider propofol, midazolam, ketamine, lacosamide, phenobarbital with the respective doses which we have mentioned. Consider consulting anesthesia for inhaled anesthetics also if these things don't work. Starting midazolam infusion is a wise choice. You can also start a propofol infusion or a phenobarbital infusion or a ketamine infusion. But among all of them, if the patient is hemodynamically stable, we prefer midazolam infusion. Sometimes we might have to use vasopressor support or noradrenaline support, vasopressin support to maintain the blood pressure. Another trial which was there, which is the trial, that is rapid anticonvulsive medication to be given prior to arrival to your ER. So they wanted to see, so the concept is that the earlier you treat the patient, the better the prognosis is, right? So for that, what the study was purposely designed to see that if we give intramuscular midazolam versus IV lorazepam in pre-hospital settings in patients with status epilepticus before arrival to the ED, did it actually shown to improve outcomes? That is the purpose of designing the study. That early treatment of prolonged seizures with benzodiazepines given intravenously by the paramedics in the pre-hospital settings has actually shown to improve some outcome. But sometimes IV access is not easy. So they tried to see if IM midazolam had the same effect as IV lorazepam. So the primary efficacy outcome is the absence of seizures at the ED without the EMS rescue therapy. And the safety outcomes are, of course, how many of them actually got intubated, how many of them actually had recurrent seizures, how many of them actually had secondary seizures after the initial seizures stopped. So this is soon under completion, and soon we will actually get the result of the study. So this is what the trial is actually, that IM of midazolam 10 mg versus IV lorazepam 4 mg, termination of clinical seizures prior to the arrival to ER, and need for a second rescue medication. It was found that both are actually similar. So even if you give midazolam versus IV lorazepam, both are statistically same. There is no difference in seizure recurrence. There is no difference in adverse effects. So you can use either of the two in pre-hospital setting before arrival to ER. What are the adverse effects we have to be concerned about? So what are the adverse effects you guys usually see in your clinical practice by using all these drugs which we have mentioned? Any one of you can name a few adverse effects. What are the adverse effects of midazolam, phenytoin, levopril? The common ones during this status epilepticus when you're trying to administer these medications. Anyone?
The known and the most dangerous is propofol infusion syndrome. But if you are talking benzodiazepines, this is another issue. But regarding propofol, this is really life-threatening condition, propofol infusion.
So what are the side effects of benzodiazepines we know of? Because we are using that as first line.
Respiratory arrest or the severe hemodynamic problems, like it can bring down the blood pressure and the...
So hypotension is common.
Yes.
What else? So what do you think? Hypotension is more with benzodiazepines or phenobarbital?
Phenobarbital.
That is what we have normally studied, isn't it? That phenobarbitons cause more hemodynamic instability. But to our surprise, actually, the latest guidelines of American Society of Neurology say that there is no substantial evidence that exists to say that. So level A evidence actually says that the cardiorespiratory adverse effects are similar in benzodiazepines and phenobarbitons. So apart from that, we have to be worried about respiratory depression, as one of you said. So these are the adverse effects. So benzodiazepines, again, appropriate initial treatment. You can use diazepam, you can use lorazepam, both are effective. But which do you think is more effective, diazepam or lorazepam? And why?
Lorazepam.
Lorazepam.
Lorazepam. Why lorazepam?
Quick onset of action, I think.
Long
Yeah. So though actually lorazepam has slower CNS penetration, but to our surprise, that the onset of action is very quick. It's only 3 minutes. So definitely lorazepam is better than diazepam. It's recommended first line. So what about diazepam? Again, good results, easy to administer, fast acting, short lasting, more lipid soluble, crosses the blood-brain barrier, anti-seizure effect is quick, duration is less than 20 minutes. Side effects we all know of, we have discussed some of it, hypotension, respiratory depression, cardiac arrest, depressed mental status, and the dose usually which you use is 0.1 to 0.3 mg per kg IV. So lorazepam, or our favorite drugs in status epilepticus, it has emerged as a preferred benzodiazepine for the treatment of status epilepticus. It is fast. It is longer acting compared to diazepam. Maximum anti-seizure effect we see within 2 minutes. It lasts for 4 to 12 hours. Longer therapeutic half-life. Maximum dose of 8 mg in total we can give. But the main disadvantage is there is rapid development of tolerance. So repeated doses are less effective. And there is no role in long-term therapy. That we all have to know for. That long-term therapy, lorazepam, has no role. Midazolam, very effective. It eliminates seizures in 1 minute. Intranasal IM buccal formulations are available. 0.2 mg per kg is a dose. And maximum up to 10 mg we can give. And infusion is recommended in refractory status epilepticus. Clonazepam is also there, 0.015 mg per kg IV. May be used as a first line, but there is no conclusive evidence for that. So 20 to 30, 40 minutes have passed after your second therapy phase. So if the seizures are still continuing, what drugs do you guys go for in your setup? Tell me your personal choice. So there are options, but tell me your personal choice. Anybody? So you have given your first line. You have given your benzodiazepines. You have repeated again also. What will be your second therapy of choice here?
Anti-epileptics, like
Which
phenytoin
one?
or phenytoin.
Phenytoin or phosphonidone. Anybody else?
You mean those mentioned here on the list?
No, which one do you use? Which drug will you use?
Which usually I use in my practice phenytoin. We don't have phenytoin or levetiracetam, but I find
So where do you work? Where do you work?
I work in Azerbaijan.
Okay. So you are using
I think European
I find always phenytoin more effective than levetiracetam. I don't know. Maybe this is my personal impression, but I think phenytoin is more effective. Is more. It's working more for the cessation of the seizures.
Okay. No, phenytoin is a reasonable choice. And what is the dose you usually go for?
Usually 15 to 18 milligram loading dose per kg, followed by 500 to 250, depends on if it terminates or not. Maintenance dose.
Anybody else wants to give their opinion apart from phenytoin or any other experience you have, any other drug you guys use?
Phenytoin we use 20 mg and initial dose, and I think European Society is supporting more support for levetiracetam these days.
Yeah. There are some guidelines which are saying that Levipril is also a good choice. Okay. And what is the Levipril dose you guys go for? Sometimes what I feel in my clinical practice is we often underdose Levipril. So what is your experience? Like anybody wants to share their experience about dosing of Levipril?
So, ma'am, we give 20 milligram per kg body weight as the loading dose.
Okay.
And
So if it's
then,
a 50 kg individual, that will come only to 1 gram, isn't it? 1000 mg.
yeah. And then we follow it up with 10 milligram per kg body weight twice daily.
Twice daily. Okay. So actually what I have gone through all the lot of literature, up to date, other websites also, it says we should load 40 mg per kg actually. So 40 to 60 of loading dose. But I have seen there is a lot of difference in various institutional practices also. So anybody else wants to share what is the preferred second line therapy? Anybody's preferred second line therapy is valproate also, or we don't use it that much? So I think
So
most
from-
of us either
from-
use Levipril. Yeah, please. Tell me.
So for my practice, it really depends on the availability. So the sodium valproate is actually quite available in the emergency department. So most of our patients will come to ICU already been given the valproate. The levetiracetam, we do have access to it, but it's not in the drug cupboard available at ease. So you're gonna have to wait for it to introduce that. So it's usually sodium valproate in my practice.
Okay.
But it's really an availability issue rather than a preference.
Yeah, that is what is the point that I guess I'm trying to make, is that there is no evidence that which is better than which. So though in many setups, so we have also moved to Levipril, probably because of the availability, side effect profile, everything. But of course, people are using fosphenytoin, people are using valproate. So these are the usual second line treatment options that are available. So phenytoin does control status epilepticus. The serum levels we have to monitor. So I know there are people from all over the world. So anybody does phenytoin serum levels? So we have to target. I know in India we don't do it that frequently. So 15 to 20 microgram per ml. It's available, but we don't do it that frequently because of the cost issues also. So the serum levels we have to target phenytoin. So sometimes we are underdosing and we don't even know. So so basically IM administration in phenytoin is not used because it can lead to precipitation in the injection site and slow erratic absorption. We have already discussed the respiratory depression and the hypotension associated with these anti-epileptic. Whenever you're giving phenytoin, simultaneous cardiac monitoring is absolutely essential. IV phenytoin, if the extravasation happens, then there's a lot of problem. Tissue necrosis can rarely occur, and also purple glove syndrome. This is a known side effect. So fosphenytoin is a water-soluble prodrug and it gets rapidly converted to phenytoin. It is absorbed better and levels are maintained at a very high therapeutic range, though it is costlier, but it is because of these pharmacotherapeutic reasons, it is preferred over phenytoin. Dosing of fosphenytoin is same, but we need to be given in a phenytoin equivalent range, and cardiac monitoring is required for this also. But because it doesn't have this propylene glycol, the cardiovascular side effects that are associated with fosphenytoin is actually lesser. Dose is again 20 mg per kg of phenytoin equivalent. That is 100 to 150 mg phenytoin equivalent per minute. And 1 mg of phenytoin is equal to 1.5 mg of fosphenytoin. So you need to keep that in mind while dosing fosphenytoin. So fosphenytoin over phenytoin, there are advantages as we discussed. There is 100% bioavailability, better tolerated at the site of infection, can be given more rapidly IV. The cardiovascular side effects will be lesser. It can be given IM also. But if you consider disadvantages, the conversion can take about a minute. So sometimes it is inappropriate as a first line, especially if the patient is actively seizing. And also there is transient paresthesia and pruritus that can occur with phenytoin. The use of phenytoin equivalent might be confusing from some of us, and we might not actually calculate the correct dose. Next comes phenobarbital. Not a very popular drug because we are all scared of hypotension, but it's very effective when it comes to status epilepticus. But there is no doubt that you have to keep cardiovascular and respiratory monitoring, and sometimes, you have to do airway protection if you're using phenobarbital. Sodium valproate is also an appropriate second-line therapy, as some of you use it also. Dosage is 30 to 40 mg per kg. Similar efficacy, but sometimes it's better tolerated. Again, valproate levels need to be done to make sure that we are giving it correctly. So it has a narrow therapeutic range of 50 to 100 mg per ml, and toxic level is more than 180. So can you tell me what are the side effects of valproate you come across in your clinical practice?
Hepatotoxicity.
Yes, what else?
I think was hyperammonemia.
Ammonia.
Yes, hyperammonemia. Ammonemia, yeah, yes. What else?
Thrombocytopenia and leukopenia happening in response to.
I also had to stop recently because of thrombocytopenia and bone marrow suppression. So there's some very sad side effects actually. These are the main common ones: hyperammonemia, pancreatitis, thrombocytopenia, and hepatotoxicity. And sometimes they are worrying, and sometimes they make us stop using this drug and go for alternatives, which is very sad. So then again, Levipril, which is very easily available. It was introduced only in 2006, and imagine it has already become so popular among all of us. European Federation of Neurological Society actually proposes that it is very useful in refractory complex partial status epilepticus. It is included in the European Federation of Neurological Guidelines, or Society Guidelines also. If you see, it has been used to control status epilepticus. It peaks in within 2 hours, steady state within 2 days. There is not much drug interactions that exist there. Luckily, probably a lot of drug interactions with other anti-epileptics, which we have to be keeping in mind. And the dose is 60 mg per kg IV over 15 minutes. So again, the concern is that we are sometimes underdosing Levipril. So there's a trial called Ellipse trial, where Levipril versus phenytoin for second-line therapy was actually, this thing. Although Levipril was not found to be superior to phenytoin in this study, together with previously reported safety profile and comparative ease of administration of Levipril, it is suggested that it's an appropriate alternative to phenytoin. So they are all saying the same thing, that though Levipril is not like a magic drug or something, but because the side effect profile is better and it is readily available and it's easy to administer without so many local complications and cardiovascular side effects, and you can quickly give it within 10 to 15 minutes, it has become our favorite recently. Not because it is a superior drug or something, just that it is fewer side effects and ease of administration is there. That is the reason. So after 40 to 50 minutes of third phase you have reached, and somehow your seizures are still continuing. So we used 3 drugs, right? That time, any of the 3 drugs. We used either Levipril or phosphonatoin or valproate. So what drug will you guys use at this point of time? Again, I want to know your personal experience and personal choice.
We may give another reloading dose of levetiracetam or proceed for rapid sequence intubation and infusions.
For resistant, we can use propofol.
Yeah. So we have to intubate at this point of time. I think everybody agrees to that we might have to 99.9% you have to intubate at this point of time. And you have to repeat your second-line therapy or use anesthetic doses. So any preference there, guys?
Propofol and thio.
Thiopenton infusion.
Thiopenton, okay. So we preferably use midazolam. I don't know, every ICU is different, every hospital is different, but if the patient is hemodynamically tolerating it, we use midazolam infusion. Our neurologists also are okay with that, and we are also comfortable with that. And we have seen good seizure control with midazolam infusion, but every center is different. I've seen using propofol. What is your experience with ketamine? Anybody uses ketamine? We also use ketamine, but Anybody else has some experience with ketamine and the dosage of ketamine you use?
So actually, we have seen that with midazolam infusion, usually seizure control after the child is having seizure for a prolonged period is not that great, maybe because of those internalization of benzodiazepine receptors. So we usually start with hyopenton, and if even after that seizure control is not achieved, we go to ketamine infusion. We use around 1 to up to 8 mg per kg per hour ketamine.
So this is, you're working in a PICU.
Yeah, PICU.
Yeah, that's really interesting to know. Thank you for that. Anybody else wants to share their experience?
My experience is first line midazolam. If that doesn't work, I will then go to propofol. If there's hemodynamic instability, maybe induced, or I see that my dose of propofol is increasing, then I might do a 1:1 ratio of ketofol, essentially, and combine those two just to reduce the dose of
Ketamine and propofol.
yeah.
Okay. So basically, these are the options available, and every institution has their own way of dealing with status epilepticus, but these are all allowed and these are all having their own bunch of side effects. And so muscle relaxants should not be used because they mask seizures. The cerebral doesn't get paralyzed. It's only the muscles which are getting paralyzed. So you have to use anticonvulsant. There is no other way to deal with this problem. Now, next is refractory status epilepticus. So failure of initial therapies such as benzodiazepines, phenytoin with seizures persisting for more than 1 to 2 hours are usually requiring agents like general anesthesia to control them. Those are refractory seizures and the prognosis is not good. We've already discussed this. Basic workup which we have to send. Infectious screen, you all know what you send. So we have to do CSF to rule out certain infections like HSV, EBV. Then there are other infectious causes which can cause seizures. We have to rule out. There are autoimmune causes. So sometimes we send autoimmune encephalitis panel, but sometimes it becomes very costly and not all antibodies are covered in that also. Then there are neuroplastic causes also, metabolic things we have to rule out, toxicological things we have to rule out. So this is the basic workup which we have to do for refractory status epilepticus. Role of neuroimaging. All patients with medication-resistant seizures should undergo MRI provided there is no contraindications. The goal of neuroimaging is just to identify the structural or functional abnormality that is associated with the seizures, and concordance of multimodal neurodiagnostic information, including ictal behavior, EEG, neuroimaging is necessary to localize the point from which all this is coming. The role of X-ray CT angiography is limited only to unprovoked seizures and not associated with vascular abnormalities. 4th generation anti-epileptic drugs, you have clobazam, topiramate, oxcarbazepine, ketamine. We all have used it at some point of time for seizures also. NMDA receptor antagonism is the mechanism of action. The dosing you can use up to 10 mg per kg per hour. Early versus late, there are more studies which are needed. We are not sure where exactly it works, but the advantages is that it is cardiovascular stable and it doesn't cause respiratory compromise like midazolam and propofol. So that is one big advantage with ketamine. And as one of our friends said that, it is very good for pediatric patients also. Alternative treatments, there is vagal nerve stimulation, there is ECT, there is deep brain stimulation, there is hypothermia. A lot of things are there. Non-convulsive status epilepticus has to be treated quickly, but the problem is that because you can't see it, you don't know it is happening. So urgency is required in this also. We will take the questions at the end of the session. Let's finish this first. Diazepam and lorazepam are more effective in treating the complex partial seizures, partial motor and absent seizures, and response to benzodiazepine might be useful in confirming the diagnosis. So how do you confirm the diagnosis? Maybe you give benzodiazepines and then see the response. Patients should be started on anti-epileptic appropriate for long-term management, and loading dose should also be given. Valproate acid is a good drug for absent seizures, and the dose is 15 to 20 mg per kg per day. So we'll just conclude. Status epilepticus, as we all know, it is a neurological emergency. If we delay treatment, there will be irreversible brain injury and high mortality. Identifying early is extremely important. Treating aggressively is extremely important. Doing A, B, C, D, E, F, G is very important. G for glucose. Don't miss non-convulsive status epilepticus. That is extremely important because use EEG when clinical seizures are unclear or patient remains altered. Tailor the therapy depending on the type and cause. Neuroimaging sometimes is important to find out the structural causes. You have to monitor with continuous EEG and give ICU support in refractory cases. Thank you.
Thank you, MONALISHA, for a very, very observing session. I think it has been tremendously interactive as well. I think you did quite well in inviting answers. This only goes to say that people have actually assimilated what you spoke. Very, very well done.
Sir, you are my teacher, sir. I've learned from you.
I think it's terrific. You know, the questions are mostly related to the type of first line, second line, third line that you do. As you said very rightly that the evidence doesn't discriminate much between the drugs that you use, right? So anybody can do it, but let me tell you, I think phenytoin is a dangerous drug if you give it very, very fast. Almost certainly, if you give it very fast, you will end up in a catastrophic cardiovascular accident, right? First, phenytoin, as you said, that it takes a prodrug and therefore it takes a little time, but 10 minutes also is quite a bit. I think you could actually, have a catastrophic outcome if you do not treat status epilepticus in those 10 minutes. You should always try and do it as quickly as you can control, right?
Yes.
There is a question which is coming very, very repeatedly that when actually do you decide to intubate these patients, right? You have said that when it goes into the 60 minutes from the onset to your control, and you haven't been able to do it, you must do it. But what exactly should be your decision how and when we should be intubating these patients? You have to give a muscle relaxant. As you said very rightly that to give a muscle relaxant, it actually doesn't stop the convulsive episodes. It only gives you the impression that patient is now stopped convulsing. But when actually should you intubate and when should you paralyze? Suppose you have, say, a continuous EEG. Can you paralyze? Because you can't see there will be lactate accumulation also with the patient is actually all the time convulsing. Is it? So therefore, give us a little of your insight into when you should intubate and how you should intubate.
So according to the algorithm which has been given and also all the guidelines, they say that 40 to 60 minutes when you enter the third phase of status epilepticus, but it is always a clinical decision for us. So when we think it is not safe for the patient, he or she is not protecting their airway, there is a chance of aspiration, there is a chance of injury. We see tongue bite, we see patients aspirating blood, we see all sort of complications. So before those things happen, for the safety of the patient, I think we should take the decision of intubation. And whenever we decide to intubate, we should go for rapid sequence induction. And the initial, during the intubation, we have to paralyze the patient. But I discourage from starting an infusion of paralysis because if we are doing a continuous EEG monitoring, we need to actually know if the seizures are getting controlled or not, if there is a recurrence or not, how much to adjust the midazolam dose. And for all those decisions, the initial dose of induction for the muscle relaxant has to be given, but refrain yourself from starting an infusion of muscle relaxant. That is what I would say. But there is no, so definitely we should wait for the seizures to get controlled after giving the first dose of benzodiazepines and loading with the second anti-epileptic. But sometimes clinically, we have to take the decision for the safety of the patient faster also. If we think that the patient is going to aspirate or patient is not responding in a proper way, and there will be more harm by not intubating, we should go for an earlier intubation as well.
Very good. I think that's a good answer that you gave. It has to be a clinical opinion.
Yes, sir.
You cannot just go by the directives that are mentioned, but you have got to, because you are actually standing there all the time. I
Yes,
think
sir.
your clinical decision hold you in good state. Can there be a dose resistance? This is one question. When you are actually giving it during status, can there be a dose resistance to the epileptic drugs? You have already partially answered this.
Yes, sir. So basically, that is the whole point of not giving the same. So suppose my patient is on phenytoin at home. At a very good dose, the patient is compliant also, taking it regularly. And I am sure, I am not sending phenytoin levels, but I'm sure with the history taking and everything that the patient's phenytoin levels in the blood might be adequate also. So we have to go for another anti-epileptic, but because probably this is not working for this patient. So we can go for Levipril or Valproate in this case instead of going for phenytoin again. So there might be a dose resistance that is actually occurring. Similarly, if the patient is already on Valproate, sometimes we ask our patients to do, at least in NHS, we had our patients to do periodic check of Valproate levels at home. So we saw that despite of the Valproate levels being in therapeutic range, patient is still having status epilepticus. In those cases, especially, you have to try another anti-epileptic instead of what the patient is already on.
How many times have you been required to start, say, 3, 4, 5 anti-epileptics in your experience, or for that matter, that you have heard? How many times do you actually see out of, say, 10 patients of status epilepticus? How many times have you found that you have to give more than 3 or 4 anti-epileptics?
So it very well depends on the cause of the status and refractory status also. As I mentioned in one of the slides, infective causes are, and some of the autoimmune causes are actually the major culprits. So two cases of status epilepticus, I saw, sir, refractory of HSV encephalitis, where we had to go up to 5 agents also. And one case of, sir, post-traumatic a brain injury 5 years after that, probably because of cerebral atrophy or some irritation in the brain. Again, the similar case, we had to go up to 5.
Yeah,
so these are the
correct.
two main causes I have seen.
Right. Now, there is a question. In a super refractory status epilepticus, what are the risks and benefits of continuous infusion of drugs? You know that you have to give quite a lot of drugs that way. I mean, what are the risks and benefits of the drugs that you use generally in such?
So we either use midazolam infusion, and if the patient is not responding to, and we can go for a continuous EEG monitoring to titrate the rate of midazolam infusion. If the patient is not responding to that, we might have to give ketamine also, and we might have to start a ketamine infusion also, or maybe we have to move to phenobarbital. So we have to manage the complications as we go. So I'm assuming the patient is obviously intubated and ventilated, and it is a controlled setting in terms of respiration. But also we have to manage the hemodynamics of the patient by putting an outline and starting vasopressors and titrating vasopressor to maintain the blood pressure of the patient also. Apart from that, the long-term complications of these drugs we come to know about later also. But first we need to achieve burst suppression. That is our main goal. So for that, we have to give multiple drugs. As you said, sir, we have to go up to 5 drugs also. We have to start some infusion of either a benzodiazepine or propofol or ketamine or phenobarbital and manage accordingly.
You prefer thiopentone anytime. You are a consultant of the present era. So have you used thiopentone? And you of course must have used propofol. So
Yeah.
how do you find the difference?
So thiopentone, sir, frankly, I have not used much. We can use, but of course, I have not used it as an infusion for status epilepticus. I have used midazolam infusion and ketamine infusion. As somebody said, propofol and ketamine infusion together. Those combinations I have tried because I find them hemodynamically we can match. Though the evidence says that, and the guidelines also say that benzodiazepines and thiopentone have similar hemodynamic stability, but we have seen more hypotension and shock episodes with thiopentone, sir. So I think I would prefer midazolam. If not, then propofol, ketamine. That will be my preference, sir.
Thiopentone, when you use, you have to be prepared with noradrenaline.
Yes, sir, definitely.
We have used that, I think, a number of years, and of course, propofol is slightly better than thiopentone. The only problem with thiopentone is that even if you stop, I think the after effect lasts for a long, long time. So at some point, you have to reduce your dose. If you have the EEG continuous, then it is better, so that the hypertension is actually less. Because you know that even if you stop it after 2 days, you will still get the effect of thiopentone for a long time to come. Maybe another 1 or 2 days beyond that, right? Propofol, you do not have this problem. But propofol, somebody asked propofol infusion syndrome, which of course I had one, and I after that have stopped using propofol. I'm very scared of propofol. Those days, earlier days, it's a very big man, and we lost him because of propofol infusion syndrome. Anyway, that is one. It's another interesting question. I think it's a prophylactic aspect. A patient with history of status epilepticus, couple of times before, coming for anesthesia for something, how would you prevent a status epilepticus? What would be your peri-operative care?
So very interesting question, sir. So depending on what I think drugs the patient is on, if I have the facility, I would like to see the drug levels like phenytoin levels and valproate levels, if they are of the adequate therapeutic range or not. And of course, if the patient is coming for general anesthesia, all my general anesthetic drugs will be having some anti-seizure effect. So induction should not be a problem. But of course, I would like to make sure that the anti-epileptics are in therapeutic range so that the breakthrough seizures doesn't happen.
You do not, MONALISHA, get in most of the places the drug levels.
Levels of the drugs,
Yes. So that will be a little bit of a problem.
But we just have to make sure that the patient has taken their medications on time, and the NPO hours also, we don't have to skip medication. So sometimes we feel that if the patient is NPO, we should skip medications also. So that we have to, I think, educate and tell our nurses that we have to give medications without fail. So if the patient is on anti-epileptics, then definitely they should not skip a single medication before surgery.
There is another question, short, but you have answered it. Of course, we have been discussing about it. What do you think about therapeutic coma in status epilepticus? We have already done that. I think this is fine. Anything else?
Can I ask a question, please?
Yes,
please.
The role of volatile anesthetics in status epilepticus?
It's a good question, MONALISHA. I think it's a very good question. You can answer that. Yes.
Yeah, so there is some evidence that volatile anesthetists do work in status epilepticus, sevoflurane, isoflurane, whatever. I think there is some role. though we have not used it, it's not available in our ICU setting or ER setting. So it is very difficult to say because we don't use it in regular clinical practice. But what I have read is that there is some role for anaesthetics.
That is that anaconda we talked about
Yes,
nowadays
yes,
in
yes,
certain
yes.
centers, and you can actually use it, but not many trials have been done. We don't use it. Yes. Any other questions? And I think
Somebody asked about autoimmune causes of status epilepticus. So I think what you want to ask is there are some evidence of use of immunotherapy in case of autoimmune cases of status epilepticus like IVIG and PLEX. So there is some evidence for it, but again, the trials have not proven it, and everything is on a very theoretical basis. But I have also come across people who use IVIG and plasma exchange in case of autoimmune cases of status. So this is a topic, immunotherapy in management of status epilepticus.
Theoretically, MONALISHA, that should be working very well.
Yes.
Okay. So your plasma exchange, I think, should be doing good in such cases, but very few cases. But you have to prove that it is autoimmune.
Autoimmune, correct. So first, either by the time results are back, it's already very late. I think 7 days it takes for the panel to be back.
Another question, which of course, again, you are the best judge. How long should you wait before you start third drug, fourth drug, and fifth drug? You know, that is the kind of thing that it's purely on a clinical basis. I think you are standing there and you have to do that. So there is nothing like hard and fast that after 5 minutes or 10 minutes, 20 minutes, right?
Yeah.
So that is it. And most of the time, of course, the patients come in status means they must be having it for quite some time before they come to us. They don't come to us immediately, right? They come from far-flung places, and then they would have had few hours elapsed before they come to us, right? So that is another issue that you have. So for every patient, it has to be different. Okay. So that is it. Any other questions that we have? That's a fantastic lecture, friends, and MONALISHA has done so well, so well. I think she spoke like a truly master intensivist and working in the neuro-intensive care unit. I'm absolutely flawless. I think it's terrific. Anything else we would like to do up before we close this session, or there is some formality has to be done?
Sana, anything we have to do? I think most of the questions we have covered, sir. I can see in the chat.
Hi, ma'am. Arpit here. So let's just leave, ma'am. Thank you very much for your session.
Yeah.
And thank you very much, ma'am. I should end the session, ma'am, right now. Thank you.